Okay. Well, thanks a lot for doing this first. That's
No problem. I apologize if my dog barks in the background. My partner will be home soon to wrangle.
oh, no worries. And I have cats that'll probably start scratching at my
Oh,
door.
good.
So okay. So yeah, we'll get right into it. So yeah, I'd like you to introduce yourself and let me know how you came to work in harm reduction and what your job entails regarding harm reduction.
For sure. Well, I'm a nurse practitioner. The last 4 years, I've been working in safer opioid supply. I first worked at Regent Park Community Health Center in Toronto the first year that the safe supply programs were launching. And then the following three, I've worked at Parkdale Queen West Community Health Center. So both of those in downtown Toronto. Um, for the last few years with Parkdale Queen West, I've also been the clinical lead with the program. So having a bit of a leadership role in sort of program design and protocols and so forth. I've actually just in about the last 2 weeks moved out of my safer supply position and am now working in a hepatitis C treatment program within Parkdale Queen West. Yeah,
Okay. So I did notice that in your title, in your emails. So how does that change affect your work? Are you moving from prescribing or to working like yeah, you can tell me how.
for sure. Unfortunately, so our program is funded through the SUAP grant, so the Health Canada Substance Use and Addictions Program, and that funding will be ending in March of 2025. So essentially, the whole program is winding down at this point. And with that, we've started trying to find new care options for most of our clients. And with that, I've actually moved out of the program the last few weeks into a permanent role because all of the funding for these things has been temporary, yearly granted funding. So I'm going to be working with a pretty similar population, working in a harm reduction based hepatitis C treatment program, working with a lot of folks who are underhoused and people who are using drugs, et cetera. So yeah, I'm no longer going to be doing safer supply, which is pretty wild for me after the last 4 years being quite a journey. But yeah.
Okay. Just hearing that, I is that kind of a movement that's happening with safer supply across the province? Or is it bigger than just Parkdale Queen
It
West?
certainly is. It's happening not just across the province, but across the country. The way that, and I'm like, oh, is Health Canada listening? I hope that I say it all correctly. But the way that the substance use and addictions program is supposed to function is really as a seed funding. So to demonstrate how a program works, that it's effective, and then the hopes usually is that the province will take up funding of these programs since healthcare is provincially funded. But these grants have an absolute maximum of 5 years. So we knew from the very beginning it would only ever be 5 years with the hopes that another funding source would be found for the programs. So all programs across the country that are SUAP funded are really facing the same things. And whether they can pivot and find a new grant, a different source of funding, tuck a program into sort of a more broader substance use program or primary care, et cetera. So some of them do continue, but the vast majority of them are really facing closures within the next year.
You may not know the answer to this, but is there um it sounds like kind of a bummer. So do you know whether certain provinces are stepping in, and is there anyone setting a precedent that way or
I think the political climate makes it extremely difficult for people to be continuing to do this work generally, but certainly these programs that um, are very designated for safer supply, where they're called safer supply. They're targets of a lot of the misinformation and campaigns against safer supply. There are actually quite a few individual providers that are providing safer supply. It's not actually something that needs to be done within a specialized program.
Okay.
Anyone that can prescribe, whether that's nurse practitioners, general practitioners, we see addictions consult teams in the hospital doing safer supply. It's within the scope of almost all primary care providers. And we do know that there are some GPs, for example, in private practice who have a handful of safer supply clients. We know that there's sort of conventional methadone providers who have taken up doing safer supply. So there is this network of people who are doing it sort of under more conventional funding for healthcare. But it's quite quiet because obviously people are a bit afraid to be talking about what kind of practice they're doing, whether that comes from the public or actually coming from fear and judgment from colleagues, from other providers. We've heard quite a bit actually from people who are what we say like the conventional addictions medicine providers, so people who've been doing Suboxone, methadone for a long time and who actually do safer supply, but they're like, well, I do, but I don't want to talk about it
Okay.
because of that judgment and what might happen amongst their colleagues more than anything else.
I just want to talk about the straight supply that you end up dealing with, um, and how it's changed over the last few years and become more contaminated, and you find less. Well, I know in media, I'm still reading outdated stories sometimes where they're mentioning heroin, and that's a thing of the past. So, do you want to talk about what you're dealing with now when people?
Yeah, heroin is very much like a thing of the past in Toronto. And I agree. Sometimes you can tell that people are maybe not up to date on their information. I'll get reports from hospital providers, for example, that'll say, like, oh, your patient is using a gram of heroin a day. And I'm like, no, I don't think so. Um, so yeah, heroin, I have quite a few clients who once upon a time were using heroin. And over time, first fentanyl started showing up as sort of a contaminant within the heroin supply. And then over time, it's become really fentanyl is the drug of choice or the actual substance that you're purchasing or intending to purchase. Um, a few issues that come along with that. One, of course, is really obvious, just the potency. We have something that's extremely strong. So if you have no tolerance, it's really high risk. It's much more difficult to be treating people with a substance use disorder because the traditional treatments that we have just don't meet the tolerance that people now have after using fentanyl. The other thing that I think we think of less often is the actual differences in the, we say, pharmacodynamics. So heroin has a much longer half-life than fentanyl. So a lot of folks were maybe doing 2 injections a day, 3 injections a day total. And in between that time, they felt well, they weren't going into withdrawal. But with fentanyl, it has such a short half-life. So it comes out of your system very quickly. It's one of the reasons why we use it in medicine so frequently. Things like procedural sedation. So if you broke your arm and you needed to be sedated for a few minutes while your bone was set, fentanyl is a common choice because it'll be in, it'll be out quickly. The thing with that is that people do need to be using fentanyl much more often in order to stay well through the day and to not be going into withdrawal. So where we once saw people injecting maybe 2 or 3 times a day with heroin, it's not uncommon that we see people injecting 8, 10, 12 times a day if they're using fentanyl. And of course, every time that you inject, you're introducing the risk of infection, you're introducing the risk of overdose, you're increasing the number of times that you need clean equipment to be injecting with. So it increases the risk of sharing syringes or needles, increasing the risk of Hep C, HIV, etc. And some of the other infections we see, like cellulitis, so skin infections, heart infections, spinal infections, etc. All of these things really increase with the number of times that you're injecting per day. So that's fentanyl itself, though.
Yep.
And I feel like one time we're like, oh gosh, like it sounds funny, but to be like, gosh, I wish it was still heroin. But now it's like, oh gosh, I wish it was still just fentanyl, because the supply's only gotten more and more dangerous over time. And what we see now in Toronto is that over 50%, I believe it's about 50% at this time, over 50% of the samples that are submitted for testing in Toronto come back with benzodiazepines. And I feel like in our medical training, we're often told, alcohol withdrawal, that can be fatal. Opioid withdrawal, it's uncomfortable, but it's not going to be fatal, which has its own problems, which I can get back to. But in its fundamentals, yeah, opioid withdrawal is extremely uncomfortable, and it can drive people to use, especially if they're like after a period of abstinence. It's certainly a high risk if they go back to using. But now the vast majority of people who are dependent on fentanyl are actually also chemically dependent on benzodiazepines. And that means when people are coming off of fentanyl, they're experiencing benzo withdrawal symptoms, even though they don't want to use benzos, don't intend to use benzos, or don't know they're using benzos. So we see people experience, on the mild end of things, anxiety, heart racing, restlessness, through to severe benzodiazepine withdrawal, where it's really not uncommon that we see people have seizures, especially if they're incarcerated and suddenly cut off of the supply. Having hallucinations, tremors, etc. And it becomes a lot more dangerous and a lot more complicated to manage. And it's at the point now where I warn people when they're starting on opiate replacement and they're starting on safer supply. We talk about, if your plan is to rapidly reduce, you need to be watching out for these symptoms. We need to be monitoring you because it can be quite risky.
Can you expand a little bit more on um, what that does? Like those contaminants have made you have to adapt how you treat people and um, in the healthcare system, like the extra problems it brings?
Oh, many extra problems. Um, well, we do have the issue of benzodiazepine withdrawal, and traditionally, when we've talked about alcohol withdrawal, for example, if people are at a risk of having a seizure or have symptoms that might lead up to a seizure, we'd usually have said that this is not safe to be managing in the community. So folks who are exhibiting those symptoms, we would send them to the hospital so that they can be in a medically supervised environment while they're detoxing. And at this point, it means essentially every single person who's a daily fentanyl user is someone that may need pretty intensive medical monitoring to safely withdraw. And that really increases, number one, the barriers to getting treatment. Can you go to a clinic and they'll give you opioids, they may give you methadone, they may give you morphine, but the comfort around people providing benzodiazepine prescriptions, for example, to someone who's already on high doses of opioids, traditionally we've thought of that as a like, never do it. Don't prescribe benzos along with opioids. It's very dangerous, and it certainly does carry risks. But since we traditionally restrict that to these very medical environments, it means that we're not able to provide all of that care in the community, or we don't have established practices about how we manage benzo withdrawal in the community, especially for folks who going to the hospital may not be realistic depending on their life circumstances, where they're living. But number two, the fact that we just don't have enough treatment beds. Even for people who are willing and able and want to go today, tomorrow, this week, very often it's several months wait time to get into a treatment bed. Or we'll send folks to CAMH, for example, and there's just no bed available. So it's complicated things a lot, and unfortunately, medical practice. I mean, fortunately, most medical practice is evidence-based, so we like to have a good base of knowledge and evidence to work with before we start doing something on a widespread scale. But the drug supply is changing much faster than we can keep up with that. And so there's things that we have to do more urgently to be helping people right now today stay alive, first and foremost. So there's very slowly, and by very slowly, I mean 3 years ago, we were talking about what are we going to do about these benzo withdrawal syndromes that we're seeing, and everyone was like, what are you doing, what are you doing, what should we do? So 3 years later, we're now seeing a few guidelines come out about managing benzo withdrawal in the community, but it's still very small, and it's still something that I think the vast majority of people aren't comfortable offering because of the risks associated. So the barriers to abstinence, if that's someone's goal, or it's certainly sort of the main goal within public discourse around substance use treatment, it's very, very difficult to get there at baseline. But it's even more difficult when the substances are getting more and more dangerous. They're dangerous to use, they're dangerous to come off of. And then we also have an environment where all of our services are underfunded. And we also, I've been seeing this push to have detox centers, let's get all these new detox centers. And I really want to see more treatment beds. I have tons of folks who really wish for residential treatment, and it's just not available. It's 6-8 months down the line if you even have the same phone number by that point so that they can contact you when the bed becomes free. But we have these detox centers, and the majority of them are non-medical. So they don't have a medical provider on site. So it's a place to go to be reducing what you're using and have, a place away from your environment, but they're really not equipped for benzodiazepine withdrawal. If someone goes there and they show up and they're having these symptoms, they send them to emerge. And when I have this whole population who every single one of them needs medical supervision and intervention to safely be coming off of a benzo contaminated supply, opening up more and more of these non-medical detoxes is really not where I think the money should be placed to address these problems. It just doesn't meet what we're seeing.
Well, I didn't even know that. I thought that there was some sort of medical aid tied in with all of them, because to me I think of it as a healthcare issue. It's
You would think so, and I definitely thought that going in. And we do have a few. So, for example, KMH in Toronto has a medical withdrawal unit. Some of the hospitals do, but they're small capacity. And then we see freestanding detox centers, which are much more common, that really only manage uncomplicated withdrawal.
okay.
And we don't have uncomplicated withdrawal anymore.
One of the big fears that's being tossed out there is diversion. And as a healthcare worker, do you feel that the diversion of safer supply drugs is a cause for concern, as naysayers make it out to be, or is it being used almost strictly as a fear-mongering tactic that is not
I'll
based on?
land somewhere in the middle.
Okay.
I mean, diversion on face value, of course, we don't want medications that we're prescribing for a specific person for a specific medical reason to be ending up in the hands of another person and not knowing what the risks of that are. But at the same time, we know that diversion happens with all medications, whether that's like, hey, mom, I can't sleep. Can I have one of your sleeping pills? I have a friend who has a migraine and you have a migraine medication and you see that they need help and you give it to them, right? Diversion happens with all medications. And it also happens quite a bit with our conventional opioid agonist therapies. So even looking at some of the main guidelines for the provision of methadone in Ontario, it recognizes that diversion has been reported by up to a third of patients who are prescribed methadone report having sold their medication at some point. And we have quite a few overdoses and deaths that are related to methadone. And that doesn't mean that we shouldn't be prescribing methadone. It doesn't mean that we shouldn't be providing people with carries of methadone. And we say carries being unwitnessed doses, because we know that unwitnessed dosing really drastically increases people's retention in treatment. So um, it's all a balancing act in that way. And when we see all these reports also about like, oh my gosh, the hydromorphone that's flooding the streets. I mean, safer supply prescribing of hydromorphone is a very small percentage of all the hydromorphone that's prescribed in each province. And to say this is all coming from safer supply when there's such a vast number that's prescribed for a variety of reasons, could be chronic pain, etc. Everyone knows their grandmother that has Percocet in their cabinet. To point to just safer supply as the cause is misrepresenting the issue. The other thing is we've seen pretty reassuring data around hydromorphone. So since 2020, since the proliferation of these programs, there has been a big increase in the prescribing of hydromorphone. At the same time, we've actually seen a reduction in the total number and the percentage of deaths that are related to hydromorphone. So prescribing went up and the deaths related to them actually decreased.
Okay.
We also have, I find it really funny because this president of the BC Association of Chiefs of Police there's some quote that they keep pulling out with her saying that this huge amount of pills that they're finding are related to safer supply. And then if you read her full testimony, she really emphasizes that diversion should not be their focus, that diversion, quote, pales in comparison to what organized crime is doing with fentanyl production. People are not dying of prescription diverted medications. They're dying because of this poisonous drug supply. So even, the president of law enforcement is saying diversion should not be the focus of things. Diversion is not a widespread issue.
Talk about the continuum of substance use healthcare and some of the middle stages, because we have like I'm diabetic and I've got high blood pressure, so we have the beneficial pharmaceuticals that you go out and get, and they're considered totally beneficial. And then at the other end, you've got uh, things that people are dependent on or addicted to. And a lot of the time, I hear people talk like there's just one of or the other in um, for substance use. You're either having something beneficial, a nice drink to after work, or you're an alcoholic, or like you can you talk about some of the in between stages of the continuum of substance use and that's
Definitely. I think I think the majority of us can recognize that people have very different relationships with a substance like alcohol. That some people may have a problematic relationship with alcohol. It may be causing really negative effects in their life. Some people find it's something that they can drink socially. It doesn't seem to cause a big negative issue for them. In fact, it's something that we use to celebrate. It's something that we sell in bars. We get together to use it. And every substance has people on that continuum. we don't hear about it because we don't, for healthcare providers, we don't go to our doctor to talk about our non-problematic substance use. But there's people who use cocaine, there's people that use heroin, there's people that use fentanyl. All of them do use every substance in problematic and non-problematic ways. So what we see when we talk about addiction, which is a word I tend to steer away from and prefer to talk about problematic relationships or negative effects. We really focus in on this very small portion of people. And I think after cannabis was legalized, for example, so many more patients were coming through and being like, cannabis, is this going to interact with this medication? Is this going to interact with the anesthesia I'm going to get? And you found out how many more people were using this substance. And if we didn't have these like massive social ramifications of sort of being out about substance use, we'd see so many more people talking about different kinds of relationships to substances. All to say, problematic substance use or substance use that's having a negative effect for someone, I often think about what is that substance, what is the function of that substance? Because there's always a reason why people are using, whether it's like, I like to feel high and feeling high is great. That's why I might have a drink because I enjoy having a drink. But for some people, there's a lot of different reasons. So we see a lot of people who are living on the street who are using stimulants, for example, to stay up all night because they're particularly vulnerable to assault if they're asleep at nighttime. We see people who have severe chronic pain, so they're using opioids. What we see quite a lot of is people who have a history of trauma. A lot of people that have history of childhood sexual assault, who have developmental trauma from family dynamics, from entering the foster care system, etc. So substances certainly do have a role in helping people cope with circumstances and very difficult circumstances. And what we see is that we don't have a lot of other options to replace those coping mechanisms. It's certainly a lot to learn a new coping mechanism, even at the best of times for the healthiest of us all. But when you are someone who's, for example, been incarcerated, can't get a job because you have a criminal record, you've now lost your housing, the housing market is crazy, you're living on the street, our public housing list is 10 years long, there's actually an 8-month wait list to get into treatment, and you don't have any of the creature comforts of life. You don't even have the basic necessities like food and a roof over your head. That's an extremely difficult circumstance in which to make a drastic change with your relationship to substances, especially when it's causing you comfort and sometimes helping you with safety, like stimulant use, for example. So we always in healthcare are thinking about the social determinants, but I think it comes into such massive focus when we're talking about substance use or when we're talking about people sort of saying, well, they just need to get sober. They just need to stop using drugs. And we think about, I always say, like, we could think about a lawyer on Bay Street with a 6-figure salary, all the support in the world, and recognize how difficult it is for someone to stop drinking, for example. And when you have someone who's got nothing and no resources, it's a nearly impossible situation to make a big change. And I don't want to say you can't, because many people do, but the amount of blame and shame placed on it is not recognizing the reality of it.
Yeah. And I'm hearing you there and thinking about how many of us do expect people to make that change, and we don't look at ourselves, we don't look at where we're saying that from, because I own a house, I have, I'm almost paid off that house, so I'm fairly comfortable right now, so it's easy for me to say I could do that when we rarely put ourselves in the other person's shoes, and that seems to be a big problem that's going on right now. So anyways, I'd like to move on to the amount of misinformation that's being spread. And I know there's a lot happening in the political sphere. We'll go there next, but I'd like to start in media because it seems to me like there's a lot of articles being written right now that where media tends to, they might be trumpeting what's going on in the political sphere, but they don't seem to be taking the time to research the whole picture. They're putting together kind of, it's almost propaganda for what we're hearing in the political sphere. Do you want to talk to about media first?
Yeah, I mean, it's funny to try and talk about them as two separate things because I mean, I think they've always been intertwined, but they're even more intertwined now with um, someone who shall not be named, writing National Post articles, Adam Zebo, who's quite focused on this issue of safer supply. And then when you're watching House of Commons sessions, he's tweeting to the House of Commons representatives a list of questions that he wants asked the person who's testifying. So it's incredibly, incredibly intertwined now. What's there to say on it? I think, I kind of always wanted to be a person that thought if people just knew all of the information, they'd come to a different viewpoint, and that people really want to find the truth and apply a fair and balanced view and have that change their opinions or what they do. But I think we have a way of sticking to our philosophical narratives and collecting what confirms it and discarding what doesn't. And certainly we see a lot of that, nitpicking tiny quotes from this chief of police that supports their argument when, the thing that she was saying was that safer supply diversion is not a focus issue for them. It's also difficult because on face value, I understand why this is a difficult concept for people, given the narratives that we have about drugs. What we hear is, oh my gosh, you're giving drugs to people who are addicted to drugs. Like, how does that make any sense at all? And it's complex. It needs a complex and nuanced conversation for people to truly understand. And that's really hard when there's very loud voices providing something that's very not nuanced around it. It's very funny because a lot of the folks that I work with don't have any access to media. The majority of the people in our program are underhoused. Maybe half of them don't even have phones. So sometimes I'll talk about, the political narrative right now or what's happening in the media. And they're like, what's happening in the media? This media is talking about people's lives and talking about their medical care and their medical decisions, completely divorced from these people's actual lives. And it's very hard to get a counter narrative out there. It's especially hard when we're busy and burnt out healthcare providers who've, been doing this grind for a few years to try and counter back. And when the people who are receiving care are not people that have a lot of agency within media or social media, et cetera. Yeah, so the misinformation is incredibly disheartening when you're on the other side and you see how much it's changed people, help them meet their goals, how much of a change it makes for them, people reconnecting with families, people who are like, oh gosh, I have all this time in my day, like I think I need to pick up a hobby. Because what we forget is the other aspect of the difficulty of just quitting drugs and recovering and going to treatment is that with the criminalization of drugs, people can get into this daily cycle where you wake up sick, You have to do something in order to get the means to purchase a substance, whether that's sex work, shoplifting, etc., which not everyone does, but people can end up doing different things to get their means. Then finding the person who sells the drugs, purchasing the drugs, using the drugs, and then waking up the next day in the same thing, wake up sick, get the means to get the drugs, etc. So this is someone's daily routine, sometimes for a decade or 2 decades. And in the middle of that, it's like, well, why aren't you finding housing?
Yeah.
um, and so when you just the act of giving someone, I always find this astounding, just the act of giving someone a substance that's not criminalized, that they can get in a known quantity at the pharmacy daily, you're not removing dependency, you're not stopping people from getting high. All of a sudden, life can change so much just from that alone. In terms of like the time that you have in your day, reconnecting with family, getting a job, applying for housing, actually going to treatment. People may not even be in a place where they can go to a therapist's office to get the kind of counseling they need for trauma. And so just getting a safer supply can be that little first step that lets you just grab onto the cliff that you're sliding down, to start making ground and start working on anything that you're trying to work on.
Okay. But I just want to focus on something that's being said in there, because the politicians want they want uh treatment centered uh response to this, but it sounds like what I'm hearing from people like yourself is that even if there's a treatment centered response, you need things, it's got to be coupled with things like safer supply, to make it safe enough for people to reach a point where they can get the treatment. And then also on top of that, if people get treatment and come out, we need to fix all these other social ills, that because people might go to treatment, come out, they're not using, everything's good at that moment, and then they're back into the daily routine, struggling to survive shortly after. So I'm trying to come up with a question from this that takes in what the politicians are saying about treatment centered approaches, and how when they're not supporting the rest of the whole continuum of treatment from the political sphere, um, how it's, do you feel it's something that's bound to fail, a treatment centered approach, if they're not supporting it in other ways?
So this is where the either or comes in too, right? We need both. And we have plenty of people who don't need safer supply. We have people who want a recovery oriented approach. We have people who are ready to go to treatment. And that needs to exist, and it needs to exist a lot bigger too. We have an issue with not having safer supply, but we have a huge issue with not having comprehensive mental health care, period. Um, so yeah, we do, like I was talking about how drugs fulfill a certain need for someone. And sometimes that's a lighthearted need, like I enjoy having a drink. But sometimes it's coping with trauma, it's coping with pain, it's coping with circumstances. And we can put someone somewhere and remove that coping mechanism, but we need to be replacing it with other ones or it does fail. People can't just remove the source of euphoria that they have in their life and carry on without it, without trying to develop other strategies and other things that make life feel good to them or make them physically well. We know that people benefit from opiate replacement therapy. So, on the chemical side, replacing in the body what that substance does chemically. But I think people also need that sort of socially replaced, what that drug is serving them, if their goal is to stop using. And there's many people also who will continue to use or use in different ways that meet their goals or does not cause them harm or pain. Um, yeah, we have huge issues, obviously, with housing. And I'm always baffled when I hear politicians talking about safer supply is causing the housing issue, or drug use is causing the housing issue. The lack of housing causes people such instability that they turn to other coping mechanisms. The other part of that is that it just makes substance use visible. Many people are inside their homes using cocaine, drinking, smoking weed, etc. And it's not a problem because people don't see it. But when it's on the street and people see it, then it's suddenly an issue. But the idea that it's that way, that it's the safer supply causing the housing shortage, like, what a scapegoat.
Yeah. Okay. Yeah, that's so I don't even know. That makes me speechless when I do hear things like that. I can't put that together how they're pulling that causation out. Is there anything you want to talk about that you feel we've missed in this that you really think's important to the conversation?
I think I want to emphasize again that it's not either or, and I don't think anyone on the side here we are with either or.
Yeah.
Anyone who's in support of safer supply thinks safer supply is the one and only answer, never mind all the other things that we have. Almost all, I think every single safer supply prescriber is also someone who provides methadone, Suboxone, slow release oral morphine. We're all people who are providing multiple kinds of treatment because we believe in multiple kinds of treatment. So that's fundamental. Also, you'll even hear people who do provide conventional OAT like methadone saying methadone itself is harm reduction. It's something that you can take and continue to be using, for example, but it's reducing someone's risk of overdose. It's reducing their withdrawal symptoms, which impairs quality of life. It decreases how much they have to use. Like, we've always been using harm reduction within the treatment of substance use disorders. And we know also that people in recovery or people who are now abstinent are at the highest risk of overdose. We see the highest risk of overdose with people leaving prison, with people leaving hospitals, and with people leaving residential treatment, because people lose the tolerance that they've had and go back to using, maybe they're using the same amount or a little bit less, but it doesn't match how much tolerance they've lost. They're at an extremely high risk of overdose. And that's where, overdose prevention services are extremely important. When I have people that haven't used in like a year, I'm like, okay, but if you are going to use, and they're like, I'm not going to use. And they're like, okay, but if you are, let's just say, like, please use with someone else, or be using at a safe injection site, or use an overdose prevention phone line, for example, because you're really the person who's at the highest risk of overdose. So we can't have recovery in isolation. It always exists with harm reduction, or it is a failure. The other thing I'll say to my harm reduction comrades who might be listening, that's helped me keep a little bit of hope in this political moment, is I've looked back at the history of the discourse around methadone in Canada and in North America. And it was really the exact same rhetoric that was said about methadone that this isn't the place of medicine. People shouldn't be prescribing drugs for people who are addicted to drugs. Concerns around diversion, concerns that this attracts crime to good neighborhoods. Like sometimes it's word for word what's being said about safer supply, but back in the 70s. So I try and keep in mind that this is a certain political moment, and things have obviously changed with methadone, where there'd be few and far between people who would say we shouldn't offer methadone. And maybe one day we'll be in the same place with safer supply or with a whole range of options for people who use drugs.
Okay. Well, thanks for taking the time to talk to me. And there was one thing, um, one line you said in that last bit that I really liked. I believe it was, you can't have recovery in isolation. And I think that's a really good uh, line. Like you need the whole picture, the whole framework, and things have to work together to
We also have
do
to
this.
give people the tools to stay alive
Hmm.
until they're in a place to access recovery.
Yep.
There's so many people who, whether it's because of their own life circumstances or because it's going to be 6 to 8 months to get into a treatment center, if you can find one that is OHIP covered, we need options for people to stay alive until they're in a place where they can make those changes. And no one should die in the process of trying to get help.
Okay. And you just said another thing that takes me back to an earlier point in the conversation. You said you just talked about OHIP covered recovery. And so I would assume that the ones covered by OHIP are the ones that do have medical facilities usually, or
Yes. And there are other ones that do have, excuse me, in our province, there's OHIP billing, so physicians could bill OHIP, for example, but we don't have OHIP covered therapy, psychotherapy, etc. So that funding is more difficult for people to get from a public pool. Whereas with a doctor, you can submit a billing code for the patient in front of you. And we have facilities that are private and then have a portion of beds that are funded by OHIP, for example. So we have even mixed ones. That might be $28,000 if you want to go next month, 8 months if you want it on OHIP.
okay.
And we have many also publicly funded detox centers that are non-medical. We have them in the city of Toronto, for example, so ones where there isn't that kind of intensive monitoring that's required.
And I just heard you say $28,000, and I'm
Yeah.
thinking, I'm not living on the street. I'm a homeowner. I can't just throw out $28,000 for um
No,
it's
that's the
like
real cost of a 4-week treatment program in Toronto. And that's a few years outdated, so I'd have to check even. But it's exorbitantly expensive if for the average person or even
yeah.
people who are above average. I
Yeah.
certainly could afford $27,000 for a 4-week stay that may not change all of the other factors that are also influencing things. Yeah.
Hmm. Okay. All right. Well, thanks again for talking to me. It's been great and informative. And I wish you the best of luck in what you're doing because
Thank
I
you.
think it's very important.
Yeah, the fight continues, everybody. It's a difficult time to work in this field, but I'm always, it's been really great work. I really love the community. I love the clientele that I see, the kind of realness that you can bring to work, bring your own personality and really connect with people, is fantastic. And the amount of solidarity also with other providers, with harm reduction workers, So thank you very much for bringing them together.
Okay, thanks.
All
Bye.
right, bye.